Managers Budget and Finance Committee. Items 6, 8, and 9 will not be discussed tonight, and those items are: item number 6, discuss and take appropriate action on healthcare service delivery expansion in eastern Travis County, including project budgets. Item number 8 is discuss and take appropriate action on the 1115 Medicaid waiver, delivery system reform incentive payment projects, and community care collaborative, including its healthcare delivery arrangements and other community partnerships. And item number 9, discuss and take appropriate action on an update regarding Sendero Health Plans Incorporated, including the effect of federal legislative and regulatory actions. The first item of business tonight is item number 1, consider and approve the minutes of the May 22nd, 2019 meeting of the Central Health Board of Managers Budget and Finance Committee. Do I have a motion?
That we approve.
I second.
I have a motion by Manager Greenberg, a second by Manager Musaitis. Any discussion? All in favor? Any opposed? Any abstaining? Motion carries. Item number 3, receive and discuss a presentation on Item number 2, receive and discuss a presentation on the process for creation and operation of a healthcare provider participation program to be administered by Central Health, which program will result in the establishment of a local provider participation fund as anticipated by Senate Bill 1350, the 86th legislative session. Presenting is Jeff and Katie.
Thanks. We will make this as brief as possible, but we bring information related to our LPPF program, both informationally, and we're actually going to request action at our next board meeting. So we want to go over what that action is and then update the board. The first question you might have is, why are we taking action so quickly? Seems like we just were out of legislative session. We have intentions to use the LPPF for our final demonstration year 8 uncompensated care intergovernmental transfer, which is scheduled for September 5th, which seems a long ways away. But in order to do that, all new intergovernmental transfer entities, including the LPPF, must have an affiliation agreement with all the participants filed to HHSC by July 15th. So that's next mid-month. We would have to have the affiliation agreements filed with HHSC. In order for us to file the affiliation agreement, the LPPF must be in existence. So due to this scheduling, we just found this schedule out late yesterday. So a clarifying letter came from HHSC that laid out all the requirements and the schedules related to these actions. So when we go out and we look at our board meeting schedules for both next week and next month, we don't have another board meeting prior to July 15th, except for the board meeting next week. So we're going to have to do a little multi-step process related to the LPPF. So we're going to propose that we establish the LPPF next week in order to necessitate the execution of the affiliation agreements to HHSC by July 5th. We will come back to the board at the July 31st meeting to set the mandatory payment rates for the uncompensated care intergovernmental transfer scheduled for early September. And then around August, around in our budget process, we will come back again and adopt the rate for the demonstration year 9 or the fiscal year 20 mandatory payment rate. So ordinarily, we maybe could have done it in 1 or 2 steps. Sounds like we're going to do it in 3 steps. So I'm going to turn it over to Katie and let her walk through some information and kind of lay some of that out a little more explicitly.
Sure. So, as you all know, Senate Bill 1350 passed. That was Senator Watson's bill that created the authority for you all as a board to create the Healthcare Provider Participation Program. That it will be encoded as Chapter 298E of the Texas Health and Safety Code. So you'll see that language coming up and documents we'll have for you. And what the legislation did was create the authority for you all to act as the administrator of the LPPF program. And in that role, you will authorize the district to create the LPPF program with the majority vote of the board. You'll hold public hearings, and those hearings are related to setting the mandatory payment rate that will be assessed on hospitals. You'll approve that rate and also adopt rules relating to the administration of the program. So the collection of payments, expenditures, audits, all of those things that you might expect as an administrator of a financial program. So as Jeff mentioned, we are going to be going through a number of these steps in succession that is probably not the way we'd like to do it because we have to do it so quickly, but we'll walk you through what that's going to look like. When in administering the fund, staff is of course going to be taking on the roles of managing the accounting, the banking for the fund. The legislation requires that the LPPF fund be separate, maintained in a separate bank account from central health revenue otherwise. So we are working with to set all of those processes up. Obviously getting legal representation, making sure we're following the correct processes and according to the legislation, audits, all of that, and of course the processes for setting up, collecting the payments, and then using those for IGT. So all of that's going on in the background, and we're working on that. All of the costs associated with those administrative tasks are reimbursed through the fund. The legislation provides for that. So as Jeff mentioned, this recent development from HHSC, yesterday we got the email that said, that clarified how HHSC wants to handle affiliation agreements between government entities and hospitals who are using an LPPF to fund their IGT for the supplemental payments. And so all the LPPF programs in the state, including all the new ones that just got approved this last session, will have to execute new affiliation agreements that reference the LPPF as the administrator of the fund, and those are due on July 15th. So without that program in existence, we can't sign an agreement as the administrator of the LPPF, hence the advanced timeline. So let's look at that. It's kind of small here, but hopefully you can see it on your slide. Just walking us through from now till September 5th, what's going to happen. So June 12th is right now. We're doing our overview, and this is the opportunity to learn about the process, ask questions so we can get you all comfortable with this. June 19th is our next Board of Managers meeting, and we will be bringing forth a resolution that we would recommend that you all adopt to create the LPPF program. The resolution will, we will have that available for you in your board packets, so you can see that in advance before going into the meeting next week. We've already got it drafted, and we're working on finalizing it. And that will create the program simply, and it will not set a payment rate. It will not assess any payment on a hospital at this point. Just create the program. That's next week. July 15th is the date to get those affiliation agreements filed. So we on the staff level will be working quickly after next week's meeting to get those executed and submitted to HHSC. And then at the next Budget and Finance meeting on July 24th, the plan will be to come back to you with more information, with draft rules and procedures that you all can review, a proposed payment rate to levy against the hospitals that for you all to consider. And then the week after that, at the July 31st board meeting, we will hold our official public hearing as required by the legislation. to adopt the program rules, set the payment rate, and also designate the depository bank, which is one of your roles according to the legislation. So from there, I'm going to skip down to September 5th because all of that activity through July 31st will then allow us to begin sending invoices to hospitals, collecting the mandatory payments that will then use for IGT for the UC payment that goes up on September 5th. Backing up a bit to the August 28th dates, that's moving on to the second mandatory payment rate that you all will need to set for FY 2020. So the one we are going to ask you to approve on July 31st will apply only to that FY 2019 payment. That will cover the uncompensated care for that, for the hospitals, for that one payment. But starting October 1 in FY 2020, we will be setting a new payment rate. The rate may need to cover additional supplemental programs, so that's why it will look different and why we need to come back to you through that. I know that Jeff and Lisa will talk to you about that as y'all talk about your FY 20 budget and the forecast that you're working on. So we can certainly talk more about that, but there will be two rates to set coming up quickly. So the next steps really are, take a look in your board packets coming on Friday for the resolution we'll ask you to consider and hopefully adopt next week. We will be working as the staff with the hospitals to determine what an appropriate payment rate would be to cover the supplemental payments they need out of this payment. And we'll bring that to you as a recommendation at the July 24th board meeting. Budget and finance meeting. And then on the 31st, hold the public hearing and adopt the payment rate to collect the funds. And that's it. If you all have questions, I'm happy to discuss more.
Okay, questions? Ms. Musaitis, please.
Thank you, Chair. Thank you for the short and very thorough presentation. I have a few questions related to dates and timelines.
Okay.
So if you can, I just want to back up.
Sure.
So for our next board meeting, you're going to authorize the creation of this LPPF, correct?
Correct. That's the plan.
So when do we figure out when the program, the details of this program? Which meeting?
The details of the program, meaning what the program will fund?
Yeah, how would it look like? All those details.
All those details? Well, the
When should
program
we expect?
itself is actually fairly simple. It's collecting money that the hospitals, because it's the hospitals paying into the program, we will listen to what programs they would like to fund with the LPPF as we work with them to set the rate. And this money is all directed to supplemental payment programs in Medicaid for hospitals. So it'll be uncompensated care, it'll be the uniform hospital rate increase program eventually. So those sorts of hospital-based programs that can use IGT, that's what the program will fund.
Okay, and
I think we have a graph in our next presentation that will show you a little bit more of the funds flow and the structure of how that looks.
I understand on the 24th, you will be presenting a proposed payment rate.
Correct.
And would you have that information for us before the 24th?
I hope it would, ideally we would. I mean, I think that's our goal. That's really a negotiation that the hospitals will be holding amongst themselves, and then we'll be working with them.
Well, the main reason why I'm asking these questions, I am actually not going to be present for the July meetings. And knowing how critical and important this is, I just wanted to make sure that I've done my homework and voiced my concerns or...
So it's really about getting information from HHSC.
Okay, so you'll know...
We're really modeling for the July 24th meeting. We're really only modeling the final payment for this year for uncompensated care. So I would expect that to be readily available, hopefully by the 24th. Again, it's just setting a rate so you have enough local funds to send up for that program. So I would anticipate we would have information about that. I'm a little worried about August just because there's a lot of modeling going on now with a lot of different scenarios for next year. And so we're kind of giving you our best guess on the rate setting for next year. But the July meeting, hopefully I think we'll have information to get to the board to look at prior to July 31st.
Thank you.
Thank you. Ms. Valadez?
If I'm not mistaken, when we discussed this earlier, when you presented to us previously, did you not tell us that each of the individual hospitals within those counties or cities that'll be participating in our, program, will we be administering those funds? Will be paid an administrative fee, but their program, each program could be a little different based on the needs of those individual areas, is that correct?
So each LPPF
Yeah.
will establish the programs that it
Bless you.
participates
Yeah.
in, and there may be different regulatory rules related to the programs that each applicable LPPF can participate in. In our Medicaid SDA, which is an 8-county region, we
Right.
have Travis,
Travis,
Williamson, and Hayes.
Okay,
And so there may be, I believe there are some different rules related to, I think, Hayes. So it just kind of depends on what the rules are related to the specific LPPF as to the programs they participate in.
so do we have attorneys that are already working on this right now?
Yes.
Okay, and they're working with the attorneys for those various hospitals and
We're
And those
working
particular counties.
with the hospitals that are in our LPPF right now, with a focus on reaching out, educating, and then obviously executing the affiliation agreements.
Okay, so for us, with respect to Central Health, since we're gonna be we're gonna be the administrator, it's not really a big deal, except that we do need to know, I guess, what the various scenarios are going to be, but it won't be a big deal, because right now, all we're gonna be dealing with is uncompensated care for this year,
For this year.
and then
that's right.
laying down the parameters for the following season, the budget season, which is gonna be a much more,
There more than
How much,
likely will be
bit-
more programs than just uncompensated care.
right, that's
We're
right.
still looking at that, and we still need to work with the hospitals related to that.
And those will be based on the needs of those particular areas, correct?
It'll be on their qualifications for those
Right.
programs and what they qualify for as
Right,
far as
right.
funding.
Right, thank you. Just wanna bring it on.
Thank you very much, Ms.
So we can do
Valadez.
this.
Any other questions? Mr. Jones?
Why am I sitting here over here by myself?
I'll come sit up.
I would be happy to.
No, my question was, so what happens if July 15th entities do not meet that deadline? What would happen, I guess, is what my question.
We would not be eligible, if we don't have an affiliation filed, we would not be eligible to utilize the LPPF for
Sure.
transmitting intergovernmental transfers
For 19 or?
for
period?
19,
For
or
19.
September 5th, which would be the fiscal year 19, final uncompensated care.
But would we be able to do it for, as we planned, for 2020?
We'd have to come back after the 15th, or at the 31st board meeting, or subsequently to that, get the LPPF approved and the payment rate, the mandatory payment rate for fiscal year 20.
Okay, all right.
So we
So the
would,
goal is to make sure we get it this year so we can close out 19.
that's right.
Okay, all right. That was it.
Great, thank you very much, Mr. Jones. Any other questions? Thank you, appreciate it. I'd like to take up item number 3, receive and discuss a presentation on fiscal year 2020 budget development and approval process and financial forecast. Presenting will be Jeff Knodel and Lisa Owens. Welcome, guys.
Thank you. And I know we're pressed for time a little bit, so I'll go through my slides fairly quick. Hand off to Lisa. We're going to stop naming how the length of period we do a financial forecast on, because we really want to look at the time period that makes the most sense for us to look at. And we've talked the last few years about looking at getting through the post-1115 Deseret program, and what do we look like after losing or after not being able to qualify for those federal funds related to that program. So hence, this year we've done a 7-year forecast through fiscal year 2026. So quickly going through slides, we've talked some about this, just to review a little bit. Fiscal year 2020 is really going to be a year of change. We've talked about some change. Just the last item related to some changes that are going on. Uncompensated care is going to be distributed, both the local and federal funds will be distributed across an 8-county SDA area rather than directed to hospitals that are, and this is effective beginning next year. There also was a decision called the DAB decision regarding facilities in Dallas and Tarrant related around a question burden alleviation model that determined those relationships were impermissible provider donations. There was an assessment related to that finding of $25 million and prompted HHSC to do a sweeping review of all the affiliation agreements across Texas related to that relationship. So that's certainly on our radar also. As it relates to some of those events, we had our legislative bills that were filed this year that now have become law. The LPPF bill, which is now Chapter 298E in the Health and Safety Code. And then our the bill that authorizes or allows Central Health to practice medicine as it relates to Chapter 281. And passage of these bills gives us some flexibility related around how Central Health both pays and delivers health care. So this is the structural diagram of both uncompensated care, the changes to uncompensated care, and how the LPPF funds flow looks. And so kind of looking at, real quickly, starting from left to right, the left are the, what we're calling the mandatory payments from the hospitals that would go to the, what's called that purple, longer purple box, the IGT LPPF. That would be Central Health and its role as administrator. The administrator would actually transmit the federal funds up to the federal government, or would transmit the local funds. The federal funds would be matched, and they would come back down across the entire SDA in a proportional calculation based on whatever program it is. If it's uncompensated care, it would be related around either hospital-specific limits or uncompensated care caps, or the amount of unreimbursed care is probably the best way to put it. This is a CMS explicitly approved financing structure. A lot of times you're not quite sure what's permissible explicitly. There is an explicit letter that CMS issued related around these structures, and we think it's a really important strategy for us moving forward. It does give us greater flexibility related around continuing to draw down matching federal funds, and as I mentioned, it complies with CMS methodology or structure related around the relationship of private hospitals using local dollars. It doesn't require any additional tax revenues, and it allows Central Health to start assessing and shifting from its current structure of an indirect payment model, which we've had in place since 2013, with our master agreement and services omnibus with Seton to more of a direct payment model related around hospital services. So, so as it relates to the timing of everything, we certainly have a lot of changes in place. We've talked about the changes in uncompensated care. There's always the risk also that disproportionate share funding reductions would occur. Disproportionate shares are part of the ACA. There's always something out there every 2 years about a 25% reduction at the federal level, which I think would translate to a little less for Texas, but those have been postponed for a number of years, but we never know when that reduction comes in place, if it's legislatively will be approved. And then our current agreements don't really incentivize the level of care that's provided. We don't have a centralized claims system. We have an indirect payment model. It's been challenging, to say the least, to obtain information, information related around reporting on service levels. The levels are set at 2013 rate levels. Those levels, it's 2019. We've seen a large population influx in this area that I think makes it difficult to suffice that we would continue providing those services at that level. We have done some transitioning out of the hospital into community care, community-based healthcare. It's extremely challenging doing that. It's too hard. We get down to the procedure code on all these specialty lines. It takes a lot of bandwidth just to move a specific service line. It's not a feasible model to try to deliver the care in the place that needs to be delivered. And then last, related to performance incentives, we really think that that's important that we start incentivizing outcomes as it relates to how we deliver and pay for care. A couple of factors that we should be looking at related around a forecast. We have both external and financial risk. I'll let you guys read through this. It's really not anything that's we haven't talked about. I will point out the last two, which are somewhat of a change as our lease revenue decreased from the Brackenridge campus. We are much more reliant on property tax now, and that has, beginning last year, and will probably continue to be challenging, related around the timing of property tax receipts. Typically, we get a large influx of property tax revenues late December and then through January, so we're always looking at cash flow to see if what that looks like in October and November around cash flowing operations. And I'm going to speed up a little bit more because I need to turn it over to Lisa. But our fiscal year 20 budget process, again, we're looking at shifting our payment model over. There's not a lot of detail that we have at this point in our model. There's a lot under discussion, but we have increased our healthcare delivery program from fiscal year 19 to fiscal year 20 in our forecast by approximately $20 million. And as we develop our budget process, we'll have hopefully much more detail to bring to the table as we develop our budget for fiscal year 20. So I'm going to turn it over to Lisa.
Okay,
And sorry
thanks.
it took longer than I thought.
That's okay. All right, so as, for those of you who've been here through past budget cycles, welcome to our new board members. This is the first step in our budget process, is to look at a longer-term forecast in the development of our budget. We use this as an opportunity or a tool for the board to look at known environment changes and prepare a draft budget. it is necessary to kind of look at the long term and look at the adequate reserves that we need and the source of funds that we need to meet healthcare delivery, to look at known changes in the environment that we know about. For example, the changes to the DSRIP program, or as Jeff mentioned, many of the changes that we're looking at today in the shorter term. So we use this tool to assist with establishing a proposed property tax rate that the staff will then go back and prepare a draft budget and bring back to you. And we will request that at next week's meeting. So as Jeff talked about, we do have a 7-year forecast this year because of the significant changes in the external and internal environmental changes. We added 2 additional years because we wanted to be able to assess the longer-term impact on our reserves. You will recall that we talk about our reserves goal being that we have about 100 days of cash on hand. And then some other assumptions that are built into the model are that we do assume a slight slowing of the economy, so an economic downturn. So we incorporated a slower growth in new construction, which is a big component of additional tax revenue to the organization. And then there are a lot of assumptions about our uses of funds, around what percentage of growth we might have in uses of funds. And on things like operating expenses, goods and services, that's a lower number, around 3 to 5%, whereas it ranges all the way up to 10% from some of our healthcare services. And then we do also incorporate an annual salary and benefit increase. So those assumptions are throughout the uses of funds, which stay standard in the models that we show you. So the uses of funds have a set amount, and the sources of funds will change based on assumptions that we've made and will outline in the different tax rate scenarios. So we have two models to present to you this evening for your consideration and thought. And those 2 models are increasing over effective, which is the tax rate that would be required in order to bring in the same amount of tax revenue next year, by 6% for 2 years, this year and FY21, and then 4.5% over that effective rate thereafter. And you will see at the bottom of our models, let me just walk through what this model shows you. It shows you the sources of funds with the blue line and the uses of funds. And so with the assumptions for healthcare services growth that we talked about, you will see in this model the uses of funds is greater than the sources of funds, with the exception of just 1 year where it's very close towards the end of the FY26. And as a result, the total reserves are drawn upon slightly each year, which results in FY26 total reserves of just $13 million and only 15 days cash on hand. So the compounding effect of our tax rate impacts the availability of sources of funds that can be used for healthcare delivery. The second model we wanted to share with you is looking at more of a steady 6% over effective rate year over year. And you'll see, as I mentioned, that compounding effect of that tax rate provides additional revenue in future years. And what we do want to see is that our sources and uses equal out. We want kind of both sources and uses. We generally have a structurally balanced budget that we bring to you. And this shows that it is more aligned in those out years, which is why we went out to the 7 years. I will point out in this, we do end up, you'll notice the slight uptick or turn to starting to increase our reserves after 2025. And that puts us at over 80 days cash on hand. Still trending towards the 100 days, not quite there yet. But again, at least we are seeing that turn so that the reserves are starting to be built up again. So the last thing I'd just like to highlight before we open it for questions is the next steps. As I mentioned, this is the community conversation opened this dialogue. Our presentation tonight starts for your consideration looking at the long-term forecast, and then we've shared the lengthy list of meetings that are coming over the next few months. So this schedule shows us returning to you next week for additional consideration on this item, as well as we will make a recommendation, staff will make a recommendation to the board, and we will ask for guidance next week on what proposed tax rate to just start a draft budget with. It's not approving the tax rate or anything, it's really just which we put in to start the drafting of the budget. We will be back in July with a proposed budget. We have another community conversation to talk through that budget with the community and make sure that people understand the structure of our budget. And then in August, we begin the more formal process of finalizing the budget, presenting to the Commissioners Court. End of August, early September, we have additional public hearings. And then we have a goal of getting the budget approved in mid-September so that it can be adopted by the Commissioners Court at the no later than September 30th. So with that, we can answer any questions.
Okay, thank you very much. Any questions?
I just-
Hold on, Ms. Valadez.
Before I leave, I was wondering if there's any action that we need to take, or is it,
No.
okay, because I like the second one. I'm just-
Thank you very much for that information. We appreciate
We'll
it.
be back next week
Yes.
to request action.
You want to go to 7%?
So you can think about it.
Yeah.
Yeah, you get time to think about it. You may change your mind.
I'll want to go up.
Yeah, right.
Thank you.
Ms. Musaitis. Thank you, Ms. Valadez.
Thank you, Chair. Can you go back to the tax rate?
The first one or the second? The model?
Yeah, so the first model you have is 6 for 5 years.
This first one that we showed you is 6 for 2 years, and then, oh,
And then
I'm
hold
sorry.
it.
You should glue us, literally, or. Okay. Now, knowing what happened at the legislative session this year, we, as a hospital district, were exempted from the cap. And I would probably recommend going a little bit aggressive, because knowing that we may be asked from other entities to supplement some of the services they may come to us, and thinking, looking at our reserves, where they are and how many days cash in hand with this proposed model, I would advocate for a higher tax rate given our position here in Texas. So that's really my position where I stand for. Thank you.
Any other comments or questions? Okay, thank you very much.
Thank you.
The next item will be item number 4. And before I lay out that item, just let me say that any one member that leaves loses our quorum. So if you need a bio break, let me know, and I can stand us at ease, and we'll come back, okay? But you guys are stuck in here until we finish.
We have like 2 minutes.
Yes,
Thank you.
stand at ease.
Be right back.
come back to order. And Lisa, well, our legal counsel is not here, but he'll step in for us. And Lisa,
Okay.
was she asking a question, or did you get your question? Okay, all right, go ahead.
Okay, so I want to present the May financials for the Community Care Collaborative. So a few highlights. No significant changes, but a highlight being that our cash is at 43 million compared to 55 million, and we talked about this over the past several months with the changes in the timing of the district program. Our cash is a little bit less due to that, and we anticipate additional district revenue in July. The CCC did receive a $6 million member payment from Seton and a $210,000 member payment from Central Health for the integral care school-based program that we had approved to Central Health to reimburse integral care through our member payment. I'm sorry, the CCC through our member payment. Liabilities at 19 million and net assets at 24 million. So real quickly, just looking at the balance sheet, total assets are predominantly cash and cash equivalents at our $43.6 million. As I mentioned, $19 million in liabilities, predominantly made up of payments due to our provider network and the different providers in our specialty and primary care line items. Total net assets of 24 million. Our sources of funds, year-to-date sources of funds are 83 million. That does consist of 32 million in DSRIP revenue, and 21 million, a total of $45 million in member payments from Seton and Central Health, and again, a $6 million member payment was received in May from Seton. And then, again, our total being $83 million sources of funds year-to-date. Our uses of funds in the healthcare delivery program, which we'll go into more detail on the next slide, at about just over $55 million. And our DSRIP project costs this year to date are $8.1 million for a total of $63.9 million. And then our net sources over uses being $19.1 million. So looking at a little bit more detail on the healthcare delivery programs, we have additional slides on primary care, specialty care, and our healthcare delivery operations departments. Real quickly, looking at specialty behavioral health, we are about 67% of the way through the year. So we are right on track with behavioral health, and that is where that additional program, the integral care school-based program, is being recorded. So that line will be a little bit over budget for that approved investment in that program. And then again, I'd just like to highlight that the post-acute care, last month you made additional action to increase the post-acute care budget to $2.3 million. And we are at about 70% there with $1.6 million in expenses. Looking in a little more detail at the primary care program, total year-to-date spend is at about 63% of our budget. Our largest provider, Community Care, at 64%, $26.7 million year-to-date. El Buen Samaritano at 69%, and then the other two providers at 60%, and People's Community Clinic. I mentioned this last month. Their contract does have significant performance incentives, so we would anticipate larger disbursements on that contract towards the end of the year. So very carefully working with our primary care partners to monitor our expenses, but again, $32.6 million in primary care expenses year-to-date on our $52 million budget. Looking at specialty care, we continue to provide additional detail on this slide for some planned investments. However, I will just remind you that last year we had the community care specialty lines all in one line item, and we've dispersed those into the type of care that they are. So for example, rheumatology, pulmonology. And as I mentioned, we do anticipate being a little over budget perhaps in one line item and under budget in another as we fine tune the expenditures in those areas and have a little more experience in those specialties that community care is providing for us. but we are carefully monitoring that. The only other highlight I wanted to provide was around pulmonology, and that is, as I mentioned, one of the community care specialties that we anticipate being under budget in another area, but not over budget on our contract, just in the type of care, the type of specialty. So total year-to-date is at $4.4 million on our $10.9 million budget. And last, we just would like to walk through the different service delivery operations departments. We are at about 40% of our budget year-to-date, $5.3 million in expenditures. This budget has been amended, so for the post-acute care and specialty care adjustments that were made last month and in previous months, you will see the asterisks where in some of our departments, we amended the budget downward, where we don't anticipate spending all the dollars in that department, and those funds were reappropriated to healthcare delivery area. But our total year-to-date, again, in those different operations is just at $5.3 million, so 47% of the year-to-date budget. With that, I'll answer any questions.
Any questions? Ms. Greenberg?
Thank you, Lisa, as always, for your thorough analysis. We appreciate that. And I would like to say that although some of these areas are not where we want them to be, I appreciate the upward trend we're seeing in spending. You know, primary care and specialty care. And we know from strategic planning, these are our high priority areas in our strategic plan. So I do like to see that we're trending upward. Thank you.
Excellent. Any other questions, comments?
Just one question.
Mr.
Just to
Jones.
make sure I understood you. Over on specialty care, rheumatology, and pulmonology, the reason you said there's no prior year experience is because this is our first time at looking at, assessing that.
No, if you look on the second line on this chart, you'll see community care, specialty care. In years past, we worked with our partners on working in these newer areas of specialty care, or not so new, but providing that specialty care. And it was just one budgeted amount, $2 million or a set amount. What we tried to do this year is break that out by the type of specialty. So we had to make some estimates based on prior year experience. And so, for example, in pulmonology, we estimated $225,000, where we may go over, but we don't anticipate going over on the contract because and I'll use rheumatology as an example, we estimate to be under there. So it's really just as we get more experience and try to provide more detailed budgeting by type of specialty.
Yeah, okay, that's what I was trying to get at. Okay, thank you.
Thank you. Any additional? Thank you very much, Lisa. You want to take up now item number 5, receive and discuss a report of the May 2019 financial statements for Central Health.
Okay. So, as we are in May, we have collected the majority of our tax revenue. However, additional tax revenue does come in, but we are at 99% of our adjusted tax levy through May, which trends, if you look at the dashboard that should be in your packet behind this, it shows that we're trending along a nice curve as we have in years past. We did not have any intergovernmental transfers in May. However, we did make a $210,000 member payment, as I mentioned, in the CCC for the school-based program that has been funded. So moving to the balance sheet, we had total current assets of $156 million. Again, in May, we have collected the majority of our $196 million in tax revenue, and we'll have a much slowing trend in our sources of funds coming in as the tax revenue has been collected almost in its entirety. Our non-current assets total $119 million, and that does include Sendero paid in capital of $71 million plus $37 million debenture. And then our capital assets at 114 million as of 5/31, 2019. So total assets are $389.9 million. Our current liabilities are just $6.7 million. I would just highlight year over year, that is slightly less due to payables last year to Seton that were paid later in the year. And so our other payables this year are just at $91,000. So total current liabilities of $6.7 million. And total liabilities are $15.2 million, which includes our long-term liabilities for debt. Total net assets at $374 million, and again, total liabilities and net assets are at $389.9 million. Our sources and uses of funds, we did have $1.3 million in sources of funds this year, which was tax revenue, lease revenue, which includes our UT Seton lease, UT ground lease, and the Seton lease for the parking garage and the CEC, and other revenue, which is interest and investment income. Our healthcare delivery was $1.5 million. Our administrative program, $576,000 this month, and year-to-date, $4.2 million, totaling $46 million. So our total uses of funds is at $2 million for this month, $143 million year-to-date. And then our excess uses over funds is 118 compared to 120 last year at this time. And I would like to highlight that our healthcare delivery year over year, if you look at our fiscal year to date versus last year, has gone up by about $20 million, which is about exactly almost the same as what we've brought in additional revenue. So our additional revenue this year is going to the healthcare delivery program. So looking at the healthcare delivery program details on the next two slides, we have had $77.9 million year to date in IGT, no expenses in May. There was $138,000 in provider costs. I would highlight that the negative primary care, we did have expenditures in primary care, which is our partnership with Planned Parenthood. However, we made a reclassification this month to our our sexual and reproductive health program to get some things lined up with that new program. So that's just an adjusting entry for this month. Year to date, $486,000 in expenses, which is about 62% of that budget. So $25 million year to date in provider costs. And then on service expansion funds, we have spent $311,000 year to date on the $4.4 million, which includes expansion funds for sexual and reproductive health, new initiatives, and then other service expansion, which we've had in years past for potential provider contracts or needs. And although we don't show an expense here, we did take action, I believe, to appropriate $300,000 of the $1.4 million in new initiatives for the Pay for Success program, the proposed Pay for Success project, and the $420,000 for the school-based program was budgeted there, but you saw it paid out in the member payment. So some great investments in some of our programs and new expansion funds being spent through sexual and reproductive health and the Integral Care program. Looking at the healthcare delivery operating costs, we did have about $532,000 this month. Year to date, we are at about 44% of our budget in the healthcare delivery operating costs. And then some other costs that we like to highlight is the campus redevelopment. We have started to see a lot more activity starting on the campus with expenditures for contracts that you've approved earlier in the year, remediation and the utilities work. And then the ACA enrollment and subsidy continues to run about $500,000 a month, and that is the combination of both the Central Health Assistance Program and the new ACA high-risk program that we rolled out this year. So this month, $767,000 in other costs. Year to date, $6.6 million, which is about 31% of that budget. So again, total healthcare delivery costs at 1.5 million, year-to-date, $138 million. So that was the total healthcare delivery. And with that, I will answer any questions.
Ms. Musaitis?
Thank you. Thank you, Lisa, as always, appreciate it. I have a couple of questions. On page 49, can you, under Sendera paid in capital, is Sendera surplus debenture? Why, because I'm looking at, for instance, Sendera surplus is about 10 million difference between,
Year over year?
yes, so why is that?
So as of this time last year, last May, we had contributed $61 million in capital, risk-based capital to Sendero. And as of this time, this year, it's 71 million. So sometime between May, I believe we made a $10 million payment between May and September of last year. So by the balance sheet is as of a certain date. So it's a timing issue. But as of May 31st, it's $71 million.
Okay, and I know that we received some payments from the 2033 fund. Where is
Yes.
it under?
So the rent from the 2033 fund that is applicable to this fiscal year would be in your year-to-date lease revenue. The on page 51, $8.4 million. We received that, I believe, last month or the month before, and it would have been
So would
In that
it be
year-to-date?
possible to break it?
out by the. You want to maybe see more detail on the lease
Yes,
revenue?
I will appreciate
Okay.
that.
Okay.
Yeah, you have a couple of different sources. You have just the campus leasing of the parking garage, the CEC building, and the parking garage for the CEC building. So that's one source, and then you have the 2033 fund. So
So
we
if we
don't
could-
break that down here. If you'd like to see a schedule, we can.
I would like that. I think it would be helpful also for the community to see the value of our lease and revenue in the future. So the potential, what could be.
Sure.
Thank you.
And then I would just add, on page 50, the rent that we received for future years, the cash that was, the funds that were received is considered deferred revenue. And-
Okay.
And this is outlined in the narrative, so we can provide a supporting schedule for that going forward, but
I
it's also
think
in the
it would
narrative.
be helpful for the community to see it.
Okay.
The value. Thank you.
Great.
Thank you, Ms. Musaitis. Anyone else? Thank you very much, Lisa.
Thank you.
Appreciate your thoroughness and excellent presentation. Okay, the committee will now take up item number 7 in closed session. The item is discuss and take appropriate action on Central Health owned or occupied real property and potential property for acquisition or lease, including the downtown campus and properties located in eastern Travis County. And we will go into closed session. I announce that the committee is convening in closed session to discuss agenda item number 7 under section 551.072 of the Texas Government Code, deliberations regarding real property, and under section 551.071 of the Texas Government Code, consultation with attorney. In addition to our counsel, Holly Grummer, the following staff may remain for the closed session. For item number 7, Jonathan Morgan, Stephen Lamp, Lisa Owens, and Stephanie McDonald. And Perla Cavazos. the Budget and Finance Committee is back in open session. Item number 7, discuss and take appropriate action on Central Health owned or occupied real property and potential property for acquisition or lease, including the downtown campus and properties located in eastern Travis County. And I am open to accepting a motion. Ms. Musaitu?
Mr. Chair, would it be acceptable for council to read the motion out?
Yes.
And then Manager Musadov can,
Because she
Echo
did
as
some
much.
editing. I'm just
Sounds
gonna
good.
mention.
All right, so the motion would be, I move that the committee recommend the board determine that obtaining additional private legal counsel is advisable for purposes of representing Central Health in connection with City of Austin zoning and entitlement regulations for current initiatives at Central Health's downtown property and in eastern Travis County.
Okay. Do I have a second?
Also,
Second.
No, you made the motion.
Oh.
Okay. The motion was by Manager Musaitu. The second was by Manager Jones. Any discussion? All in favor?
Aye.
Any opposed? Any abstaining?
I'm abstaining, right?
You have
Yes,
Manager
abstaining.
Zuniga abstaining on that motion. Okay, motion carries. Item number 10, confirm the next regular committee meeting date, time, and location. The next Central Health Board of Managers Budget and Finance Committee meeting is scheduled for July the 24th at 2019 at 5:30 p.m. Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. Do I have a motion for adjournment? I have a motion by Manager Greenberg, a second by Manager Musaitu. All in favor?
aye.
Any opposed?
No.
We are adjourned.
thank you, members.